The humble intravenous catheter, or DRIP, as it's normally known, is probably one of the most important innovations in healthcare in the last 200 years. If you think of any patient that goes to hospital that requires a clinical procedure, requires theatre where they may require an anaesthetic, or are simply ill and require hospitalisation and medical care, access to that patient's venous system is imperative. Without access to that patient's venous system, we wouldn't be able to give that patient or administer those intravenous fluids for hydration, intravenous medications, and importantly, if they have a serious infection, intravenous antibiotics. Globally, approximately 1.75 billion cannulas are inserted in hospitalised patients every year, a huge number. What's quite astonishing is that 40% of patients that have a DRIP will have one fail during that one course of IV therapy. If we extrapolate that across the world, what we're saying is that approximately, or hundreds of millions of patients are having their cannulas falling out, blocking, failing during that one course of IV therapy, where they then require the reinsertion of another catheter. When we decided to look at what were the reasons why these catheters were failing, we were surprised to find that there really wasn't much data on why these devices were falling out, blocking, getting infected. There was data on the fact that they were failing, but nothing really telling us why this was occurring. So a group of clinicians and researchers headed by the School of Nursing here at Western Sydney University decided to undertake a study and undertake a clinical audit across a few hospitals to see what was actually happening. Because of the importance of the study and because of keen clinician interest, we found that those few hospitals soon became a few hundred hospitals. Over 800 hospitals in 50 countries wanted to register and be part of the study. We eventually conducted the clinical study, and we were able to screen over 85,000 patients. We now have data on over 45,000 cannulas. We will now be able to review this data. We will be able to ascertain what contributed to these failure rates and be able to then feed that back to clinicians, incorporate these findings into clinical guidelines so that we can improve the care of these patients. Some of the key findings that we found were that if you had a cannula inserted in the hand or in the elbow, it was more likely to fail. If you had a technician insert that device, or a doctor, it was most likely to fail compared to if you had a nurse insert that device. What was probably one of the most important aspects of this study, and when we're talking about hospital-acquired infection being a serious problem, and particularly multi-resistant organisms, so golden staph and those types of organisms. What we found was that over 45% of patients that had a cannula didn't have an IV order for fluids or for medication. These were redundant cannulas. They didn't need to be in. If we extrapolate that internationally, we are talking hundreds of millions of patients across the world having a piece of plastic, direct connection to the patient's venous system, being a serious risk for hospital-acquired infection. In developing nations, such as here and in the US, we have antibiotics, we have trained microbiologists and doctors that can treat infections. But in places such as the Democratic Republic of Congo, where my friend Ellie is from, who participated in the study, the infection rate in these countries is 20 times greater. They don't have intensive care units. They don't have intravenous antibiotics to use. For them, a serious infection means fatality. It means increased mortality. So on that note, we've been able to developed these findings, and we are now starting to translate this research into clinical guidelines. And we are hoping over time that our findings from this large study will eventually make IV complications history.